Hello, everyone. Today we are going to talk about one of our molecular residual disease protocols, Protocol 2022-0726. This is a phase 2 study designed to assess the efficacy of two drugs, regorafenib and a drug called XMAB20717, which is an immunotherapeutic drug in high-risk patients with colorectal cancer who have radiographically occult disease, but molecular residual disease that is identified by circulating tumor DNA after the end of all their therapy, which is considered definitive therapy. So when we look at this study design, the first thing that comes to our mind is what is molecular residual disease, or what is radiographically occult molecular residual disease? Um, This kind of disease is identified by circulating tumor DNA. Tumor DNA is the DNA of tumor cells that is being continuously secreted in your bloodstream. And now we have developed technologies to identify that tumor DNA so that we can identify not only which tumor it is, we can also identify how much is the burden of that disease. So this circulating tumor DNA test is highly sensitive, and it is more sensitive than a CT scan on picking up even small amount of what we call as micrometastatic disease. So when you have a tumor and it grows at one point of time, it starts to secrete this DNA into the blood. The tumor continues to grow, and at a different set of time, it will become apparent on a CT scan or an MRI or a PET scan. And this is called as radiographically overt disease, or disease that you can see on radiographic imaging. However, tumor DNA gets secreted in the bloodstream even before a cancer can become radiographically overt. And therefore, you can identify small amounts of tumor that could be in the body that you cannot detect by a scan using this circulating tumor DNA. So we are going to call this MRD, or molecular residual disease. In the title, we also say that these are high-risk patients with colorectal cancer. So why are patients with MRD high risk? When we look at molecular residual disease and across all stages of colon cancer, we recognize that in patients with stage 2, stage 3, and stage 4 disease, the number of patients who have this tumor DNA in their bloodstream keeps on increasing. And when you look at patients who have stage 2 and stage 3 disease, if they are ctDNA positive after their surgery or after their chemotherapy, their chances of recurrence within a year is as high as 70 to 80%. So 70 to 80% of patients that were ctDNA positive but did not have a scan that showed cancer, within a year will show some signs of cancer on that scan. On the other hand, if you are ctDNA negative, so there is no tumor DNA in your blood that was identified by these tests, the chances of that recurrence is as low as 10 to 20%. So this is a very strong prognostic tool. We recognize that the biology of disease in this really early stage is very different from the biology of disease that is an established metastatic disease. So once the cancer cells nest and gain home in the liver or the lungs or any other organ, they have already developed mechanisms of avoiding the body's immune system. And some evidence of this is upcoming, where we have seen that although immunotherapy by itself does not work in patients with established metastatic disease, when you give immunotherapy to microsatellite stable patients in an early stage, you actually start seeing activity. Furthermore, There is also a difference of activity whether you have liver disease or lung disease, which also points towards the fact that the biology can affect these patients and a subset of these patients. So the combination that we are using in this study is regorafenib and an immunotherapy drug that targets two major immune checkpoint inhibitors. These immune checkpoint inhibitors are molecules that suppress the body's immune system normally, and cancer cells use these immune checkpoint inhibitors to escape the immune mechanisms. So when you inhibit these immune checkpoint inhibitors, you are basically revving up the immune system. And you need some modulators to help you rev up the immune system further. And one of those modulators is a drug called regorafenib, which changes the milieu of the body of the tumor's microenvironment such that it becomes more responsive to immunotherapy. In a recent study where regorafenib was combined with nivolumab and ipilimumab, which are two different drugs to suppress these two immune checkpoint inhibitors, in established metastatic patients or stage 4 patients where you could actually see the disease on the scans, the response rate was about 36% with patients who did not have liver metastases. So we feel that if we bring this aggressive immunotherapy approach to an earlier stage where the cancer has not yet established that immunosuppressive tumor microenvironment, we would be able to bring about better responses, possibly cures. So the study enlists all stage 2 to stage 4 patients who have completed what is defined as standard of care definitive therapy for them as per the treating physician. And despite completing all of that treatment, when you do their ctDNA, it is still positive. If it is positive, this means that they are at a high risk of recurrence, and these are the patients that we are going to target using this strategy. All of these patients will be either screened through standard of care or through the MD Anderson Intercept ctDNA program. If they are ctDNA positive and they do not have any disease on their scans, they would get treatment for 6 months with regorafenib and XMAB20717, and they will be getting ctDNA and scan surveillance every 3 to 6 months for about 2 years. The primary endpoint of this study is ctDNA clearance at 6 months. We will be enrolling about 16 patients in this study, and our hope is that we would achieve a clearance rate in about 30% of these patients, possibly more. So that is in brief our protocol, which we call as RX-CROME. It is a study of regorafenib and immunotherapy agent XMAB20717 in patients with high risk colorectal cancer for recurrence, i.e. those patients that present with molecular residual disease, no scan evidence of disease. Thank you.